Good afternoon. I'm Laura Chatterton. I'm the nurse practitioner that's going to perform your cardiopulmonary assessment today. I'm going to start by examining the thorax and lung regions, looking first for a general assessment of the rate, rhythm, depth, and effort expressed during breathing. Normally, the rate is 14 to 20 breaths per minute in the patient. I want to look for any obvious signs on the face of distress during breathing, such as pursed lip breathing or nasal flaring. I am also going to be checking the patient's color or pallor or paleness of their face and other exposed skin areas. I'm going to be looking at their fingertips for any signs of cyanosis, as well as in their lips, oral mucosa, and tongue. At the fingers, I'm also going to look for any signs of clubbing, which is a spreading and rounding out of the fingertips. And I'm also going to be looking at the capillary refill, which should rebound in under 3 seconds. Next, I'm going to listen for any audible sounds of breathing, such as wheezing or stridor. I want to inspect the neck, looking for any obvious signs of jugular venous distension. I want to ensure that the trachea is midline, as all of these would represent issues with breathing. Next, I'm going to look at the musculoskeletal structure of the chest, both posterior and anterior, looking for any deformities such as scoliosis or kyphosis. I'm also going to be looking for any barrel-chestedness, pigeon-chestedness, or any funnel chesting, as these would also compromise breathing. I also want to observe for the use of any accessory muscles during breathing. I'm going to be look for the contracture of the sternocleidoid mastoid muscles, the scalenes, or retraction of the supraclavicular region during breathing, especially during inspiration. During expiration, contracture of the intercostal muscles or abdominal oblique muscles would also indicate an abnormality. Anterior posterior diameter is an important measure. In this patient, we would simply measure what that area is as compared to the lateral chest measurement. An AP diameter ratio typically is 0.7 to 0.75 in a normal individual. Patients who exhibit barrel-chestedness, this measure is usually 0.9 or greater, and that measurement can increase with age. As I look at this patient, there are no obvious abnormalities in the musculoskeletal structure. He's not using the accessory muscles, so I can move forward with my exam and start to look at movement. As the patient breathes in and out, I want to look for symmetry in the rise and fall of the chest and also synchronicity with the breathing. I want to ensure that there's no delay in movement or unilateral lag one side versus the other, or in fact any delay in breathing on either side. I also want to just look quickly to see if there's any signs of chest wall edema, which on this patient there isn't any notable swelling. And next I'll move on to palatable crepitus. Crepitus is nothing more than air trapped in the subcutaneous tissues, usually the result of a pneumothorax of a patient. You would typically hear a crackling or grinding sound as you palpate over bones, joints, or skin. This patient has none of those, so again, we have a normal finding. Our next test will be tactile fremitus. Using the ulnar aspect of my hand, or you could use the bony portion of your palm, I'm going to be feeling specific regions. I'm going to be asking the patient to repeat the number 99. As I feel for the vibrations posteriorly and anteriorly, what I'm actually checking is the palatable vibrations emanating from the bronchiopulmonary tree out towards the chest wall, and I'm looking for symmetry in these vibrations. If there's a lack of symmetry, then I could have an issue. If it's increased, it will indicate lung consolidation, collapse, or fibrosis. If it's a decreased, it's an obstructive pulmonary disease process, or it could mean that the pleural sac is filled with air, fluid, or just simply pleural wall thickening. This patient is symmetrical on all fronts, therefore a normal finding is rendered. Next, I'm going to check for the chest expansion. I'm going to check it from a posterior aspect first. I'm going to put my thumbs at roughly the location of the 10th ribs. I'm going to move both thumbs slightly medial to the spine so that I create a gentle skin fold. And then feeling with my hands the rest of the area, I'm going to ask the patient to take a nice deep breath in and out, noting the movement of my thumbs as the patient's chest wall moves. This should move somewhere between 2 to 3 centimeters in a normal finding. And this is something that I would normally repeat here in the anterior portion, but I'm going to defer for purposes of time. Having checked all of these, I'm going to next move on to percussion. With percussion, I'm going to use my left middle finger, and I'm going to strike that interpharyngeal joint with a brisk, wrist-like motion from my right on that interpharyngeal joint. Each area of percussion will be struck twice. It'll be struck such that it penetrates the skin somewhere between 5 and 7 centimeters. There are 14 points of percussion on the posterior. As I move down, I'm going to be listening to the sounds of these notes. And I'm going to move along each of these walls, noting the relative sound. As I move, I want to note that the sounds are going to be flat, dull, resonant, hyperresonant, or tympanic. If the area is dull, we have a situation of most likely consolidation or fibrosis. If it is hyperresonant, it's either a COPD, asthmatic, or other obstruction. Resonance is the normal sound. The 14 points on the back, the 12 points on the front were all within normal limits for this particular patient. Next, using the same methods of percussion, I'm going to estimate where the region is of diaphragmatic excursion. Using the percussive technique, I'm going to move down the patient's back in a medial and lateral manner, and I'm going to be listening for areas where that sound goes from an area of resonance to an area of dullness. On a full inspiration and expiration, I'm going to note what that distance is as I percuss from an area of resonance to dullness. That distance is typically between 3 to 5.5 centimeters on a patient, and that will represent the relative level of the diaphragm. Now that I've done that, I'm going to auscultate or listen for the lung sounds, noting the pitch, intensity, and duration of each. I want to also observe for any silent gaps that exist between the inspiration and expiration. This is going to help me determine the sounds that are normal for those regions, knowing that the sounds are vesicular, bronchovesicular, bronchial, or tracheal in nature, depending on the location. As I work my way down the back, I follow that same ladder-like pattern that I did when I performed percussion. I'm going to do both the posterior and anterior aspects. And in our patient, again, because we have a healthy individual so far all of our lung sounds are what I would expect. There's nothing that gives me any pause for concern at this point with this patient. I would want to know any adventitious lung sounds such as crackles or rails, wheezes or rhonchi, any stridor, any pleural rub or mediastinal crunch. All of these would represent adventitious or added sounds. Next, I'm going to move on to determining whether there's any consolidation in the lung fields by performing 3 tests. The first is egophony. I'm going to ask the patient to repeat the phrase ee, ee, as I listen. I'm trying to observe for any of these ee sounds becoming aa sounds. Where those sounds change could indicate an area of consolidation and would be notable in my findings. The other test I can perform is bronchophony. Again, I'm going to ask the patient to say ee as I listen. I'm sorry, with bronchophony, I want to have the patient say the word 99, 99, and I'm going to be listening for those sounds to become louder or clearer. If they do become louder or clearer, it's simply because it's over an area of consolidation, since the sound transmits better through fluid than through the normal fluffy air fields. Lastly, whispered pectoriloquy. I'm going to ask the patient to whisper 1, 2, 3, and again, any areas where that's louder or clearer could indicate a field of consolidation that I'd want to make a note of. All right, so in our patient, everything looks normal. Lastly, I want to palpate for the supraclavicular area for any node enlargement. It is not typical to feel this. Supraclavicular is just above the clavicle and kind of around the notches of the neck. I'm going to then feel for the infraclavicular, which is just below the clavicle. And then lastly, I'm going to palpate for the axillary nodes, starting at the posterior portion, going down to the lateral aspect of the chest wall, and then to the anterior portion. In our patient, There's nothing that we've noted as being enlarged and therefore normal findings. Next, I'm going to transition to the cardiac exam. Having evaluated the patient's relative blood pressure and heart rate during this exam, I'm going to ask the patient to lie down. I support their neck with a pillow so as not to stress the SCM muscle. With the head of the bed elevated at roughly 30 to 45 degrees, I want to make notes of a few things. I'm going to ask the patient to turn their head to the right and using tangential lighting, and then to the left. I'm going to be looking specifically on the right for the external jugular vein and then looking just over to the side, or rather to the medial aspect, looking for the pulsation of the skin, which would be indicative of the internal jugular vein. Once I note that pulsation, or the highest oscillation point, using a straight edge, I want to mark where that area is horizontally and have it intersect at a right angle, a straight edge held at the sternal angle, and make note of what that level is. By creating a right angle, I can see here that our patient's is at about 2.5, and anything under 3 centimeters is considered a normal finding. So here we note that our patient's jugular venous pressure seems to be in line with expectations. This is an important measure because it helps us to approximate what the central venous pressure in the right atrium is. And the reason the right side is used is because it lies above the superior vena cava in the right atrium and therefore gives us the best and most accurate measurement. Next, I want to move on to palpation of the carotid pulse. To do so, I want to look for the area of the neck that lines up approximately with the cricoid cartilage associated with the trachea. I'm going to palpate using 2 fingers, and I should know a few key characteristics of the carotids. First, I want to note its amplitude, or the relative pressure that gets exerted, and I also want to note for the upstroke, the summit, and the downstroke of the pulse, or the contour. In this particular case, a normal finding is an upstroke that is brisk, the summit is smooth and rounded, and the downstroke is less brisk. And in our patient, we are able to palpate this. It's important to note that when you're palpating, you only do one side at a time. You don't do both sides, as you could cut off important arterial blood flow to our patient. Since our patient has a very good amplitude of the carotid pulse and the contours are within normal, I also would want to know any thrills or any bruits. So I'm going to actually listen. I didn't know any thrills, but I'm going to listen to the carotid by using the bell portion of my stethoscope. And what I want to hear is a nice flow of blood. Okay, and everything appears fine for that. Next, I want to move on to the region of the precordium, which is the area above the heart and the chest wall. I want to look for any obvious scarring, any implantable devices, or any abnormalities structurally, which I don't find in our patient. I want to palpate beginning with the second intercostal space on the right to the sternum. This represents the aortic region, and I want to just feel for a light pulsation and note any abnormalities. Moving over to the second intercostal space to the left, this represents the pulmonic region. Going down the margin of the heart on the sternal region on the left side, I'm going to feel for the tricuspid area. And then lastly, I'm going to end at the fifth intercostal space, about the mid-clavicular line, for the apex of the heart. When I'm at the apex of the heart, I want to determine what the point of maximal impulse is. This is typically in a normal individual the same as the apical impulse region. You want to have the patient lying supine with the head of the bed elevated at about 30 degrees. If you're having trouble feeling anything, you could have the patient turn to the left lateral decubitus position. You want to use the pads of the fingers of the first 4 to locate where that impulse is felt, and then do a finer measurement with just one finger to assess the characteristics. The first characteristic is the location, and again, it's typically at the 5th intercostal space, could be at the 4th. You could take a measurement of it in relation to either the mid-clavicular or mid-sternal line as a way to fine-tune its location. You want to note the diameter of that impulse. It's usually about 2.5 centimeters, or it's roughly the size of a quarter. You want to note the amplitude. It should be brisk and tapping. And you want to note the duration. Typically, you can look at that in terms of putting your stethoscope on the patient's chest and listening for the heart sounds in relation to what you're feeling as you're listening. And this just gives us an idea of how long that movement of striking the chest wall lasts. And in this patient, we've got everything that's looking normal. Next, I'm going to place my hand on the patient's chest, and I'm going to feel for any lifts during ventricular contractions. During ventricular contractions, if there is a notable feel, then I could have an issue with the functionality of the heart. It's normal for that chest to rise and fall during inspiration and expiration. And here I'm not feeling anything during the ventricular contraction. I also want to use the fingertips in the regions to feel for any thrill, which I'm not noting. That again would be those palatable vibrations in the heart. It could be indicators of murmurs, which we'll talk about in just a moment. Everything seems good here. Then I'm going to percuss for the left cardiac borders. I'm going to start by locating that fifth intercostal space and the mid-axillary line, and I'm going to percuss in a medial fashion towards what will be found as a dull area. Once I've gone from an area of resonance to dullness, I'm going to note that I'm at the left cardiac margin, meaning I'm right near heart tissue. Next, I'm going to have the patient sit up, and I'm going to auscultate the 5 regions of the heart, starting with the aortic or to the right, then to the left, the second intercostal space for the pulmonic, then the Erb's point, which is the third point. It's on the left margin of the sternal border. Here would be a good sound, or a good place for me rather, to determine whether or not there's any heart murmurs, as those are typically found in this Erb's point. The next region I'm going to look for is the tricuspid area, and then moving again over to that 5th space, I'm going to listen for sounds at the apex of the heart or the left ventricle. You'd want to auscultate using both the diaphragm of the stethoscope as well as the bell, because you will hear different sounds with the diaphragm. You'll hear the S1, the S2, and typically with the bell, you'll hear the lower sounds, the lower pitched frequencies. Okay, with that in mind, having auscultated, I want to next check to see if this patient suffers from an aortic murmur. If I believe that they do, listening at the Erb's point with the diaphragm, I'm going to have the patient just lean slightly forward. I'm going to note here that the S1 is less than the S2, and I'm going to listen for that turbulent flow that's notable of murmurs within the heart. Here, the patient has no aortic murmur. Next, I'm going to check for the mitral murmur by having the patient lie down, and I'm going to position the patient into the left lateral decubitus position, and using the bell of the stethoscope, I'm going to listen for the murmur, and also this position helps to accentuate for the 3rd and 4th heart sounds. And again, this patient has no murmurs, which is all very good. Lastly, I'm going to check for peripheral vascular abnormalities. I'm going to ask the patient to lie down. I'm going to look for any signs of swelling in the arms or hands, also in the legs, especially the lower leg regions. I'm going to palpate pulses radially, ulnarly, brachially, then femorally, popliteally. Going to go to the dorsalis pedis and the posterior tibital region. When I'm looking, I'm going to grade these pulses 0 to 4. 0 means absent, 1 plus means it's diminished, 2 plus pulses are normal, 3 plus means bounding. All of our patient pulses are 2 plus. I'm going to look for any signs of pitting edema, skin deformities, or decoloration. I'm going to look for any varicosities. As I look for any pitting edema, it's important that I note the depth and the duration of the depressions. This concludes the pulmonary cardiac exam on our patient. All of our findings were normal, and we hope that this helps you better understand how to perform such assessments. Thank you.